Our next speaker is Dr. Tomohiro Tada. Dr. Tada is the CEO of AI Medical Service Incorporated, the chairperson of Tada Tomohiro, the Institute of Gastroenterology and Proctology, and visiting lecturer, Department of Surgical Oncology, Graduate School of Medicine, the University of Tokyo Hospital. Dr. Tada received his MD of School of Medicine in 1996 and PhD of the Department of Surgery in 2005 from the University of Tokyo. He trained in colorectal surgery at the University of Tokyo Hospital. We welcome Professor Tada to talk to us about the roadmap to develop artificial intelligence in endoscopic diagnosis of cancers. Yeah, thank you.
Thank you for your introduction. I'm very honored to present this precious meeting. I am talking about roadmap to develop artificial intelligence in endoscopic diagnosis of cancers. Here is the outline. Shiwa is here, and here is the outline of our today's talk. First, I would like to talk about why we need endoscopic AI. And second, our research and development of endoscopic AI. And lastly, we were struggling to get to endoscopic AI real-world implementation. So, sorry. First, I'll talk about the gastric cancer status in the world. And gastrointestinal cancer is the #1 cause of the cancer deaths worldwide. These cancers consist of colorectal cancer, stomach cancer, esophageal cancer. And there are approximately 4 million cases cancer deaths, new cancer death cases, and 2 million deaths in the worldwide. This is the Japanese data shows a 5-year survival rate of cancers by cancer stage in Japan. If detected and treated at earlier stage, for example, gastric cancer can be cured. And 5-year survival rate is almost 97% if detected at earlier stage, at stage 1. However, 5-year survival rate of gastric cancer dramatically fall down to 64% and to 47% from stage 1 to 3. That is why early detection of is essential to improving cancer survival. To improve cancer survival. However, early detection of gastric cancer is very difficult and challenging. For example, these 3 images contains early gastric cancer, but early gastric cancer emerges from a background of gastritis. So this is very hard to detect. And these regions are early gastric cancers are here. As you can see, early gastric cancer is flat and do not stand out. And therefore, even for experienced endoscopists, it is very difficult to detect early gastric cancer. According to some studies, up to 26% of gastric cancer is overlooked during endoscopic examinations. But recent advances, recent technologies and procedural advance may help. And deep learning is features by feature learning, is very good at image recognition, improved computer power, and clinical big data is now available. So as a result, endoscopic AI is now possible. However, no AI product for upper GI have regulatory approval in Singapore. Now I would like to talk about our research and development. To develop endoscopic AI, we collecting data from more than 100 top-level institutions in Japan. After data collection, we annotate it and use it to develop a prototype. I studied more than 30 to 40 articles on endoscopic AI, and as a result, I think what is most important to develop endoscopic AI is quality and quantity of teaching data is a most important thing in AI development. First, I would like to talk about introduce our lesion detection system. In 2018, we published a world-first report on the use of AI in gastric cancer detection using still images. We reported 98% sensitivity for lesions above 6 millimeter in size. We reported 92% sensitivity in gastric cancer detection overall. We also published the world first publication on video-based gastric cancer detection. Can you move the video? Start the video. So we evaluated video-based detection sensitivity because videos are used in real clinical settings. AI demonstration 94% sensitivity for video button is maybe in the movie under the movie. Okay. In 2021, we compared the performance of AI and to the performance of endoscopics. AI was much faster than endoscopics at lesion detection. AI showed 58% sensitivity, while the endoscopics showed 31% sensitivity. AI greatly exceeded endoscopic sensitivity at detection. And this is an interesting image result because as you can see, endoscopies, every endoscopy shows a wide range of performance at gastric cancer detection. So endoscopic accuracy is scattered like this. AI exceeds the sensitivity of some expert endoscopies. We expect that using AI will mean that all endoscopies can perform like experts. And also we expect that AI will raise the bar for endoscopics performance. However, low PPB, low positive predictive value was an issue for our first AI. So at first, we reported AI was PPB only 26% at lesion detection, lower than endoscopies. So we built advanced AI using additional gastric ulcer images. To improve detection specificity, we retrained the AI with more than 4,000 gastric ulcer images. PPV improved up to 92%. sensitivity remains, although sensitivity remains the same. We concluded that advanced AI correctly ignored gastric ulcer lesions. Now I would like to talk about using AI to classify cancer lesions. In 2021, we reported on gastric cancer classification with magnified endoscopic NBI imagings. The sensitivity of AI was 98%, and the specificity was 100%. We concluded that AI with magnified endoscopy NBI image can classify gastric cancer with high accuracy. We also gastric cancer published article on gastric cancer classification with magnified NBI videos. The AI classified gastric cancer with sensitivity of 87%. The performance of AI exceeded 2 of 11 expert endoscopists. We concluded that AI can classify gastric cancer with high sensitivity, equivalent to or better than endoscopists. We also reported the use of AI in determining tumor invasion of depth. AI classified lesions into 2 groups based on probability score. Group 1 was M2 SM1. This lesion can be resected by endoscopic resection procedure. And group 2 is SM2 or deeper. And this lesion is surgical resection. AI shows accuracy average of more than 94%. So we also shows that AI can also help not only detecting and classifying, but also AI can help in making treatment decisions. Now we talk about the potential for AI for future endoscopic AI. We also developed and reported AI on esophageal squamous cell cancer. We compared AI to 21 endoscopists. The AI showed higher sensitivity than endoscopists. Endoscopists showed sensitivity of 75%. AI showed 85% sensitivity. But AI showed lower specificity than endoscopists. We do endoscopic examination not only by AI, but with AI. AI and endoscopists do the endoscopic examination together. So if AI and endoscopists see the movie together, sensitivity increases and specificity remains the same, almost same, 91%. So I think this is the future of endoscopic medicine. AI and endoscopists working as a teammate, and the quality of endoscopic examination increases. Another Japanese group developed an AI to predict colorectal cancer lymph node metastasis. The artificial neural network was trained on clinical pathological feature data. This AI model predicted lymph node metastasis more accurately than current guidelines. South Korean group developed AI that predicts colorectal cancer lymph node metastasis using histology preparatories. The AI model predict lymph node metastasis with great accuracy than the JSCR guidelines. The rate of unnecessary surgery may be decreased. Also, the Dutch data developed AI model to predict therapeutic response in CRC using endoscopic AI. Training AI took place with both image and clinical feature data. The AI model predicted complete response to chemotherapy and accuracy 75%. This is also contains a movie. AI also being used in a surgical support role. The Japanese AI shows the shows the connective tissue layer, and AI shows the connective tissue layer during endoscopic surgery. Push the button. Okay, thank you. And so blue images is AI artificial intelligence support. So surgeons can easily see the connective tissue to dissect. So AI shows connective tissue layer that is surgically resectable in real time. Now, I would like to about the AI to real-world implementation. It is desirable to implement AI for these reasons. Today, for endoscopic examination medicine, I think our current problem is endoscopies are overworked by many examinations. But cancer reasons are very difficult to find, even for early stages. So cancer lesions often overlooked. Lately, there is a big performance gap between beginners and expert endoscopists. So these are current problems. But I think AI can solve these problems. This is my opinion of the impact of implementing endoscopic AI. There will be several impacts of implementing endoscopic AI. AI is good for patients because AI decreases missed diagnosis, and AI will make a greater diagnostic accuracy. So also AI is good for doctors because it decreases workload, and also it bridges the gap between expert and non-experts. I would like to introduce our first product, computer-assisted CAD-X for gastric cancer. We have a prototype demo in the front of this hall. So if you have a time, please try our AI system. This AI supports doctors by displaying the lesion's degree of similarity to neoplastic lesions. Our AI connects to the endoscopic system, just a one SDI cable, and AI display the result of diagnosis. This is also a video. please.
これなんかはですね、これもなんかちょっと胃炎でね、胃が荒れてデコボコしてるだけなんじゃないかなと思うんですけれど、これも内視鏡検査中にすぐ AI 呼び出してきてですね、これはもうがんの疑いが高いので、ちょっと一生懸命検査しなきゃっていうことを内視鏡に教えて、本当に胃炎のようにちょっと胃が荒れてるだけみたいな、こういうのを、がんであると、がんの疑い高いと教えてくれます。これなんかはですね、これはまあちょっとこれも荒れてデコボコしているように見えるんですけれど、これは良性の胃卵なので AI はローコンフィデンスがんではないと診断いたします。これなんかもですね、これもちょっとデコボコしてるんですけどね、胃炎でデコボコしてるのか、病変なのか微妙なんですけど、AI を出すとこれもがんであると、がんの疑い高いと正確に鑑別してくれます。最後ちょっともう一個ぐらい。これもですね、そうですね、ちょっと胃が荒れてるだけかなと思われるかもしれないんですが、やはり AI だとですね、がんの疑いが高いと教えてくれて、このように早期のがんの見逃しを、この内視鏡 AI を使うことでですね、半減、究極的にはゼロにできると考えています。次、これなん
So, we are based in Japan, so the worldwide leader in endoscopic medicine, endoscopies per million, per population is very many endoscopies are here exist in Japan. So Japan have more endoscopies than other countries. And furthermore, there are many diagnosis of gastric cancer because in Japan we have a gastric cancer screening system, so and gastric cancer training system. And as a result, look at the right of the slide, gastric cancer incidence and mortality. Gastric cancer incidence in Japan is very high, but mortality is very low. And there's a big gap between incidence and mortality. And this means that most of the gastric cancer in Japan is detected at early stage. Maybe almost 80% of gastric cancer in Japan is detected, is diagnosed and detected at early stage. But other countries is not, and this is not the same in other countries. As well as in USA and so on, most of gastric cancer is detected at advanced stage. Maybe 80 to 90% of gastric cancer is detected at advanced stage. So there is a low gap, almost if diagnosed as gastric cancer, this means that mortality rate of gastric cancer is almost the same in other countries. So, we are now encouraging collaborative research with leading institutions in Europe, Asia, and the Americas, and also National University Hospital in Singapore also. Early detection of gastric cancer is very important. So our endoscopic AI will save all patients around the world, I believe. Early this year, we opened an office in Silicon Valley in San Francisco, and now opening an office in Singapore. Our mission is to cause worldwide advances and to save more lives using Japanese endoscopic AI. So we will continue to make efforts to prevail our endoscopic AI to the world and contribute to the advance of endoscopic medicine around the world. Now is for a summary of my today's talk. Number one, endoscopic AI is, there was many research and development of endoscopic AI. So endoscopic AI is ready for real-world implementations. So we are this is time to discuss how to collaborate with AI. And number two, the performance endoscopic AI is high in certain tasks, but more advances will come. And third, AI will soon become an excellent teammate to endoscopies. And thank you for your time and attention.
Okay, question? Okay, yeah. Any questions from the floor?
Hi, I'm Paulian. I'm a colorectal surgeon. Very exciting technology and talk. We've been having some experience with polyp detection in colonoscopy. And I think the next step is to determine different type of polyps, and then we can decide the treatment there, which I think is going to be the next step. And I think it's exciting to have AI helping us in endoscopy, exactly as what you say. One of the concerns, maybe it's slightly off topic, but one of the concerns is training our next generation of endoscopists. And if you have AI telling you all the time, a lesion is there, a lesion is there, do you think that our next generation of trainee endoscopists is going to lose that ability to detect themselves a lesion when, especially if the AI is not there? And I'm not sure. I'm sure some of the other experts here will have that concern as well. How are we going to train the next generation of endoscopists in the next era of AI?
Thank you for your question. This question is often asked in Japan, so also, but I think my opinion is just the opposite side. With AI, endoscopist is trained quickly. As in Japan, it is said that to be an experienced endoscopist, we need 10 years and 10,000 endoscopic examination experience. But with this AI, endoscopists can do endoscopic examination with expert endoscopists because our AI is trained with Tokyo University Hospital, Cancer Institute Hospital, and so on. Beginner endoscopists can do endoscopic examination with our AI. Is like expert endoscopist is beside the beginners trainees. So I think learning curve is become much shorter, and maybe more the lead time to train expert endoscopists will be shorter. But this is my opinion. So we have to provide the data after implementation by our endoscopic AI to the teaching hospitals.
Okay, we've got a question from the left side.
Hi, thank you for your great talk, very innovative. I'm Peter from Sydney. I'm a colorectal surgeon. My question to you is, with this technology and as clinicians, how much more time does this add to your endoscopy? Because we have to complete our list in a certain time frame. So did you have to change your patient list when you introduced this technology?
Thank you. This is often asked question, and this is also often asked question. So with this AI, maybe we have to recheck with the AI. So the regions with AI. So maybe it takes longer to finish examinations with AI, but for chronic colon AI, and there are some papers that shows with AI, maybe 2 or 3 minutes time is prolonged to the examination. More additional time, maybe 2 or 3 minutes. But for upper GI, I think 1 to 2 minutes more time will be needed with AI examination is probable. But what is the purpose of doing endoscopic examination is to do accurate diagnosis. So to do endoscopic exam, 1 to 2 minutes more time, required time will be acceptable in my opinion.
Okay, one last question.
So I'm a gynae oncologist, and I can just maybe relate to some other situations which we do in cervical cancer, because it is coming quite common now to use AI for visual examination to aid it, especially when you have a lot of field workers or paramedical workers or nurses trained, and then you use these algorithms to to maybe select cases better for a colposcopist. So I don't know gastric, but I think as you pointed out, there are a lot of countries in the world where we do not have trained or properly trained endoscopists, whether it's colposcopist or any other specialty. So maybe implementation-wise in the real world, this will have a big impact. That's my just a comment.
Thank you.
Yeah, thank you for an interesting talk. I have one main question is, you have trained your model on Japanese endoscopy images. Don't you think you also need to train it on other populations? If I'm coming from, obviously, from the experience looking at pathology images, we know that the training has to have a wide range, and it could be, I don't know, but it could be that the endoscopy in the Western part looks different. We know that the histology between the Japanese cancers and in the West is different. So don't you think you need to expand your training and also include endoscopic images for more and more populations?
Thank you. This is also a good point. So we are making a contact to do a joint research with worldwide hospitals, and we are planning to gather teaching data from these hospitals.
Okay, in the interest of time, we'll move on. Thank you very much, Dr.
Thank you.
Tada.